Molly, you made a mistake in giving me a microphone. So it's really not often that I get to introduce one of my very favorite colleagues on a national level and a close friend. So I'm going to ask you to indulge me for a second while I tell you about the amazing Gabrielle Rock. So the first thing you should know about her is that other than being an amazing woman and researcher, she grew up in Hanover until the age of 10 when her father was actually on faculty at Dartmouth-Hitchcock. So today is a bit of a homecoming for Gabrielle. I first met her when she was actually an oncology fellow and had written a paper that to this day is informing my work. And it was a paper that showed that patients with advanced cancer who were hospitalized had very, very short life expectancy. And all sorts of implications come from that concept and how we deal with hospitalizations in patients with cancer. And then I got to know her better when she was chair of our national organization, the American Society of Clinical Oncology's Quality Committee. And I learned very quickly that Dr. Rock was singularly driven to improve the lives of patients with cancer by improving the systems in which we deliver that care. Today, she's a breast cancer oncologist and an associate professor at the University of Alabama's NCI Designated Cancer Center and has an R01 studying the implementation of patient-reported outcomes, which she is going to tell us about today. She's made her mark showing that care can be advanced and costs can be reduced through novel approaches to care delivery, whether that's collection of PROs or deployment of lay navigators. Everyone here has experienced the hope that technological innovation would solve the problems of healthcare today, only to confront the reality that so much of this so-called innovation has just added to the burden of already overworked clinicians, impeding instead of facilitating meaningful communication with patients. So Dr. Rock is here today to share strategies for how we evaluate new tech and novel care delivery strategies while avoiding the pitfalls that come with hindered workflow. Thank you.
Okay, can you hear me? Yeah. So thank you for that very kind introduction. So I am delighted to talk to you about one of my favorite things, which is how to integrate technology into healthcare. And here are my disclosures. So I'd be remiss in not mentioning that much of this work, and I think the previous speaker set me up perfectly for this, has been really driven by the transition towards value-based healthcare. So for those of you who may not be familiar with this, the oncology care model is Medicare's payment reform, and we have used this platform and the additional dollars that we received as part of this, and I'm not gonna get into the weeds on the model, but we use that to both meet requirements and move forward our system and leverage technology to take better care of patients. And this shows you the places where the model was used, and this is a model that ended about a year ago, and we'll be looking at the future for this. So the oncology care model was really an opportunity for us to transform our healthcare delivery system, and for an institution like UAB that isn't necessarily always the quickest ship to turn, they were interested in becoming leaders and helping Medicare define this model and put our toe in the water, since at the time we really weren't doing a whole lot in terms of value-based healthcare. So I'm kind of starting at the end of the story from that model, which is we did very well financially. So we ultimately netted about $10 million for our health system of additional money into the system, partially from the upfront payments that we got for our infrastructure support, but then also from the back-end payments from lowering our total cost of care. So how did we do this? I think it's important to think about how do we redesign healthcare systems, and in particular use technology to efficiently meet requirements and do the right thing. So the requirements are shown here for what we had to do as part of this program, and I'm gonna focus on developing out a care plan from the Institute of Medicine. And I'm using this as an example. Although I know that many of you are not in the oncology space, you can take the principles of this experience and apply it to any place where you have requirements that need to be met and thinking about going beyond checking the box and really what can you do to redesign the system. So this was going to be our hardest point to do in our system because there was really very limited data. I'm not sure why Medicare put this into the model in the first place, because there was maybe 2 studies at the time that showed in very small populations of breast cancer that it did help patient knowledge, communication, coordination of care, and preparedness. But as I'm sure you have all faced when thinking about implementing something new and large, documentation was all over the place for how do we pull this together into a, quote, care plan that we're going to deliver for the patient. We didn't have a system, and the medical staff did not want to do any additional things. There was no way that I was going to be able to go to my partners and say, I want you to create one of these care plans during your clinic visit and hand that to patients. It was just not feasible. So we looked around and said, what are our partnerships? How can we do this in a more efficient way? So we had an administration who had bought in because of wanting to participate in this model. We had physician champions across our different disciplines. We had a very strong navigation program that included both lay and nurse navigators. And we found a technology company that had experience with survivorship plans, which we thought we could mold into meeting our treatment planning needs. Within that, the thing that I was the most excited about is they also had patient-reported outcomes. And that was something that we as an institution really wanted to do, but hadn't figured out how to pull that in. And so if we could pull these things together, meeting the requirement of treatment plans, but at the same time bring in the patient-reported outcomes, that was felt to be a win. So we started in the way that I would recommend that you start these types of processes, with a very small pilot. So we wanted to work out the kinks. So this is a study that we published where we, on a small group of breast cancer patients, implemented this treatment planning process. It delivers these beautiful algorithm-driven care plans that have personalized content based on that patient's cancer type, their treatments, and importantly, what they filled out on their patient-reported outcomes. So we're already starting to get to a point where we're using that patient data to guide what education that we give. So what we see here is what were the impact on quality measures, and we used quality measures from our large disease society, the American Society of Clinical Oncology, and I've only showing you the measures that looked better, but some of them were the same. But what you notice about the measures that look better, and I'm not going to go through all of them, but they're mostly things that were surrounding documentation issues. Did we identify, that a patient had pain? Did we do sort of psychosocial screening? And did we do kind of advanced care planning? All things that we built in to the patient-reported outcome components of this treatment planning document. So all of a sudden, we have a way to capture that in a more rigorous way that's not relying on the physician to document that in your notes in a very inconsistent way, often within free text that's hard to follow. So we quickly identified from this pilot, again, this is why I highlight the importance of starting with a pilot, that we needed other things to be doing this in a broader way across the system. And in particular, we needed electronic integration and integration with a medical record and a treatment dashboard. And this was our version 1 of the treatment dashboard. I'm going to show you what it looks like now later in this talk. But really thinking about how do we get the information that's needed for the clinical teams in front of them without having to have them look through a 15-page document of what's being printed out for the patients. So that pilot then had to transition into doing this for all of our cancer patients. And I think it cannot be emphasized enough that these have to be team efforts that pull in all of your stakeholders. So yes, the physicians and the clinicians are important, but I would argue from a workflow and personnel standpoint, your nurses, your social workers, your navigators, those are the people that need to be at the table if you're doing significant implementation work. And our administration was definitely involved because we needed their financial support. We needed to be moved to the front of the IT line instead of the back of the IT line. And we needed those information technology partners to really work with us on data integration. So this is a sort of simplified version of how our workflow was when we rolled this out across the system. So new patients came in. We had a nurse navigator who filled out the clinical documentation. We had a lay navigator who would work with the patient, go through the patient-reported outcomes, sign them up for a portal, make sure that the system worked. Those came together into this creation of the document that I showed you before, and that ultimately met the requirement. but it did a number of other really important things for us. It gave us documentation in the record in discrete fields of clinical parameters that we also needed to put in for Medicare for our reporting. It gave us an entry point for our lay navigators, a piece where everyone was expecting them to show up in clinic, and they were reviewing the distress assessment and the data that was coming through to help guide their workforce. So at the time that I last pulled this, we had done over 7,000 patient surveys. We'd completed over 4,000 treatment plans. And all of those are data points that we're using for research, for quality improvement, and to continue to improve the system. They have common data elements. It's nice because we can use these across systems that are using the same platform. And that patient-reported outcomes component has been really foundational for how we've moved forward. So I'm going to highlight one area where we're using that patient-reported data that has really taken off, over the past 5 years, and this is in the depression screening. So within the patient-reported data, we did a PHQ 2/9, and so as a screener for depression. And so that was a part of these surveys that we were doing, feeding into that treatment plan. And this is really an opportunity for us to understand who is at risk for depression and how are we going to manage those patients. So I worked with one of our fellows at the time, and she, dove into this data to say, what's the impact of depression and on health-related outcomes for patients with cancer? And so while this was early, we saw that, about 15% of our patients had some type of depression, with a relatively small amount initially with severe depression and 9% with moderate. I would say as this data has matured, it's a bit higher than this, but I think you get the gestalt that, it's not a small number of patients when you look at a population level. And importantly, when we start to break down the cross between the depression data and our functional status data, which is measured using this ECOG performance status, those people that were, highly functional really didn't have nearly as much depression as the people that had the severe depression. Was largely in patients that the wheels were falling off. They were no longer physically able to do all of the things that they had previously been able to do. And this really highlighted a need for better palliative care engagement. So we recognized that in many situations, the depression was also related to the symptom burden that patients were having. So this was the birth of our psycho-oncology program. And so this shows you a timeline from 2016 to 2019, how we have evolved using this data, bringing it to administration, getting to hire more people, and iterating on this process to the point that we now have this wonderful program led by Dr. Sylvia Huang, where that includes both counselors as well as a training program for patients as well, and have built in additional triggers within our regular EMR day-to-day clinic workflow as well. And so this is data that she presented at the recent Quality Care Symposium. Since 2019, we've screened almost 100,000 patients. Their average annual volume, 32,000 people. We've gotten to most people, and if you look at the rates of screening in our clinic, we are now approaching 98% of patients that are screened. And importantly, another place where we're using technology, these screens are coming through in reports where we're having somebody call and using telehealth. The majority of patients who are receiving this service are doing it from their homes, and that has really helped significantly with the adoption. So we've built on that platform, and we are now doing a series of different screens. So our new patients coming into the clinic are getting a distress assessment to really understand all the different domains of problems. And for those of you who are not familiar with this, this includes practical problems, emotional issues, your typical physical symptoms, and that becomes the launch point for the navigators. In addition, we have a health literacy screen, a financial hardship screen. Those are used by our social work team to help provide the patients with additional interest or additional support. We have clinical trial information there, and then decision-making tools for the physicians who are seeing the patient in clinic. And this is a screenshot of a piece of our EMR, the piece that I'm interested in as a physician before I'm prescribing intense chemotherapy. I can see, what are the top 3 things that that patient wants me to consider when making a treatment decision, and then how frail or fit are they? Am I worried about this person having more complications? Do we need to have them come in sooner if I'm going to give them an intense chemotherapy drug? And it tells me why they're frail or fit. So in a really quick minute, I can look at that information and have more than just the eyeball test of that patient walking in the room. Because frankly, the eyeball test is sometimes wrong. I have a number of lovely ladies who put on lots of makeup and come in and see me, and sometimes they're actually not as functional as they look like when they actually come into the room. Oops, I went the wrong way. So we're now preparing for the next round of value-based healthcare, which is going to be the enhanced oncology model. And what's interesting about this is they're taking the old requirements and they're adding on these social determinants of health screens, which frankly we're already doing, and electronic patient-reported outcomes. So this has been a big focus of my work recently, has been the implementation of remote symptom monitoring with using patient-reported outcomes. This is based on work by others, including Dr. Ethan Bash. So this is the data that preceded the implementation, in which patients were randomized with advanced cancer to either a weekly symptom assessment. And what that means is they fill out something electronically, and a nurse responds if they have a problem. And when they do that, compared to people that got our standard symptom monitoring, they looked at quality of life, emergency room visits, and survival. And what we saw with this is that there is about a third shift from patients who are worse quality of life to improved quality of life. So 31% more experiencing quality of life improvements. And importantly, this also had a major bearing both on utilization and survival. And so we see here that the survival difference was about 5 months, 26 versus 31.2, just for having patients report and managing them earlier. No new drugs, just having them report, with a hazard ratio of 0.83 and an absolute 5-year survival benefit of 8%. So this was one of my favorite ASCO slides ever. So this was the discussion section where the discussant compared the study that I just showed you to the recent drug approvals in oncology. And what you see there is that this would have been the second best drug or intervention of the things that had been recently approved. And I will have you take note that that is 2016, and we are here in 2023. And our system is one of the early systems, Dartmouth has also done this, that is really taking the lead in implementing this many years later. And why is that? Because it is not that easy to do. It's not something that you can just order like you can a pill. So Dr. Bash had come to UAB a number of years ago, and I had asked him, so what happens when Medicare puts us into their next payment model? And he said, we need implementation studies. So that's really why we started to work on this space, is to really prepare our communities to do this kind of work. So now what happens at UAB is a patient comes into the clinic, and I as their physician, and hopefully my physician partners do this, say, as part of how I provide care, we like to make sure that our patients are managed proactively for their symptoms. I'm going to introduce you to my navigator that's going to get you set up for a remote symptom monitoring program. And I'm done. And then I hand off to a navigator who does the really heavy lift of getting the patient signed up, making sure that we have their email address, making sure that they understand how to take the survey, which really only takes about 2 minutes, but they often need to be walked through that to get the confidence to be able to do that independently at home. Then the patient gets their weekly symptom assessment, either on their mobile phone or any type of electronic device by email or by text message. They get a self-management plan based on the Oncology Nursing Society guidelines with basic information on symptom management. And importantly, if they have a moderate or severe symptom, there's an alert that goes to my nurse, who then calls them on the phone and uses our regular symptom triage pathways to manage them more effectively. And then when they come back to clinic, I have all of the data, as does my pharmacist and the rest of the nursing team, to understand what's been happening with them week to week. So it sounds great, but I'm going to go through very pragmatically a number of lessons learned and pearls and things that we've thought were important as we've been going through this process. So the first is that integration is key. In our beta pilot of this, which I'm not showing you, we had 2 separate systems, and I thought there was going to be a mutiny because the nursing staff said, I am not going to another system. Like, I'm only interested in doing this if it is in my system in a place where I can access that without logging on somewhere else. So we built this so that it integrates in and comes into the results section, which is important from a data operability because you can use that discrete data in a lot of different ways if the interface is such that it comes in this type of results, at least in Cerner and our EMR. So another issue that we ran into early on was similar problems with workflow where the nurses said, I also don't want to document in two places. Not only am I not willing to go into another system, but I need efficient documentation. And so we built their response platform to help with the documentation. So when they come in and they look at an alert, they pick from a drop-down list their recommended activity that they might be doing for that symptom. If they want to write a note to the patient, they can. It's pretty rare that they do that. They can write a note if they want into the system, in this internal notes and comments, and they acknowledge. This takes a few seconds for them to actually do the documentation piece. So the bulk of the time is spent doing what nurses should do, which is interacting with patients, problem solving, and doing that clinical care. And then they automatically get a note in the chart. So as soon as they sign, it drops the note in the chart. They don't have to do any additional documentation. And importantly, the note, oops, I've gone too far, hold on. The note has all of the needed components. When the alert happened, what the alert was, what did they do about it, their signature, all of the pieces that we would otherwise having them type in to make this something that's feasible to do in a busy clinic practice. Also, my physicians want this information for their review of systems. So again, thinking about your systems and how can you get more out of the technology and the work that you're doing. So I have a nice nurse note, and then I have in my clinic, an automatic thing that fills in with their most recent symptoms and their most recent alerts. And not only does this help me with my documentation, but it also is a good cue for me to look and say, ooh, this patient didn't tell me about this problem that they had in clinic. So as I'm filling this out in my note, it gives me another chance to review what were the issues that have been happening over the last month. This is a view of our current dashboard with the symptom management piece, and this is an actual patient of mine with the dates all blocked out who had come into clinic, was on one chemotherapy drug, and right about where there's those 3 ones for her functional status, 1 being good, I put her on a new medication. And so this is what happens when she alerted. This came out on a Friday afternoon where she was all of a sudden saying that she's pretty much bedridden, having terrible diarrhea, nausea and vomiting. My nurse calls her, gets her into clinic that afternoon. She goes into our infusion center, and she's got not great blood pressure, but we give her a couple of liters of fluids and talk to her about actually taking her anti-diarrhea medication. And she went home and didn't get admitted that weekend. So I guarantee this woman would have been in the hospital that weekend had we not had this proactive symptom management. Additionally, you can look at this longitudinally. So if you have a patient who has more chronic symptoms, you can get a sense of, is this really new, or is this something that we've actually been dealing with for a while? So the longitudinal data, I think, is very helpful for clinical teams actually managing the patient day to day. So I mentioned that this has been something that we're doing formally as part of a grant. So we are evaluating those implementation outcomes, and this gives you a little bit of a view of just up until January of this year, we'd enrolled about 500 patients overall in our system, and we break that down by cancer type. And the breast is first because that's where we rolled out first, but they're all coming along, and this has been generally very well accepted. I work closely with Mitchell Cancer Institute. They're a smaller center, and so they've also had a pretty steady accrual over this time as well. So I think there's a couple of key reports that have been really helpful for us. And so what we learned throughout the course of the first year or so doing this is we need to get data back to those teams in a way that it's quick, easy, and understandable. So this is what we're currently using to understand month to month how many people get enrolled in the program compared to our total population, places where we're not rolled out, places where we missed people. And so I feed this back every month to the leadership of our lay navigators who are enrolling these patients. And we sit with them and say, what's happening in your disease group? Why are we missing these people? And it allows you that iterative feedback. It's not perfect, but it allows us to know where our holes are if we have a particular person who's, say, not enrolling very well. We also have been monitoring our patient compliance over time, so we don't expect 100% of patients to fill the survey out every week. I make a fairly aggressive goal of 75%. Other people nationally might say that that's a little high. But in reality, the majority of the time, if we send the surveys, patients fill them out. And I think that is because we're not just sending them a survey to ask them what they think of us. We're sending them a survey to take better care of them. And they're used to getting those callbacks, and they understand that this is something that's going to help them get quicker care. So another thing that we've been monitoring very closely is our time to acknowledgements. So back in May of 2021, we were not following our institutional norms of trying to get to all patient calls and contacts within 48 hours, and really worked closely with our nursing leadership to get that up. We're now in the 70-80 range, which is what our goal is, to make sure that we're calling patients back in a timely fashion. So this is when the alert comes through, how long does it take for us to call the patient back, resolve the problem, and close that alert? And so this is very much in line with where we want to be, but something you have to constantly monitor. You have to say, are we starting to dip? Do we need to do additional education? So I think the monthly audit is very important to continued implementation success. We also pull our alerts and provide this back to the clinical teams, and this just gives you a sense as to some of the types of symptoms that patients are experiencing, with pain obviously being fairly common, but also a lot of GI toxicities, things that we can manage if we know about it early. There are lots of options for how to manage that. So this shows you a bit about what are the actions taken by the clinical teams. So they're notifying the doctors, they're notifying the teams, but a fair number of the time they're prescribing getting a medication prescribed. They are referring to a specialist. So we really are capturing that data in the system. Yes, I made the notes very friendly for the nurses, but it also means that I have a system that captures data that we can track what's happening to these patients and what are the interventions that we're doing. So we've done a lot of diving into the data and looking at, how, is it different between different groups? And one of the things that we had originally hypothesized was that the nurses would react much quicker to the severe alerts than they would the moderate alerts. And we actually found out in reality that doesn't happen. What happens is it's in their workflow. It just comes into their box and they just take care of it. They've built that in to their workflow in a way that they're not necessarily triaging alerts. They're just able to kind of keep up with that volume over time. So a couple of other success stories, places where we've really seen wins. We had a patient who had complained of urinary symptoms, prompted her to get labs, who had high calcium. We were able to treat that, again, as an outpatient, didn't get admitted. We've had patients who we've been able to save them from not having their procedure canceled. So we had one patient who was short of breath, figured out that she needed her pleural effusion drained before she went for her vertebroplasty. And I think about the downstream consequences of not identifying those symptoms. Had that patient showed up for her vertebroplasty, hypoxic, they wouldn't have done the procedure. They would have canceled it. That's an inefficiency for their system. And then we'd have to reschedule, and it just causes a lot of disruptions versus getting this patient in and her needs addressed earlier. We've also been able to identify a number of new toxicities. The oncology space has a lot of new drugs that have toxicities that are less common or comfortable than our typical chemotherapy. One of them is pneumonitis, and so identifying that shortness of breath early, getting patients on steroids so that they're not ending up landing in the hospital. So I think it's also important when you're doing projects to be flexible and to listen to your teams. So when we think about how do we get feedback from people, oftentimes systems do these very formal evaluations, and we are doing formal evaluations of this as well, interviews and those types of things. In some cases, it's a consultant who comes in and gives you information on what you should do. And that's important, but I would also argue it is equally or more important to do the continuous feedback with your staff. So many of the changes we've made to the system, and in particular to the technology, has been based on either the patients talking to the staff or the staff directly coming to us, or when we go back to check on them, say, how's this going? Is there anything you can improve? them making suggestions that we're taking back to the technology partner and improving the system. And I'm going to talk about some of those improvements that we've made, not necessarily from a formal process, but from the feedback that we're getting on a regular basis from the nursing staff. So this is a long list of adaptations that we've made, based on, feedback from them. I'm not going to go through this, but I have the references to the papers in here. So one example is the nurses said to me, I really hate that people alert for fatigue every week or insomnia every week. They're like, this is not an actionable symptom. Now, we had a lot of arguments about whether or not they could be referred to exercise or get a sleep medication, but the reality is those symptoms are fairly chronic symptoms, so maybe not the best for a weekly assessment. So we actually listened to them, and despite the fact that it was a little different than the trials, we dropped those. And they said, but what I really want to know about are rash and urinary symptoms. Those are things that I think are really important for us to know about on a week-to-week basis. So we've substituted those out. And I will say, in addition to sort of having more actionable symptoms, when you listen to your nursing staff and you make changes, they're much more willing to continue to work with you, to continue to partner, on these types of projects. So I think the listening is very key. So the other thing I learned is that nurses have a different workflow than physicians. So if you say to the physician, this is going to come to your results tab, your in-basket, they're like, cool, sounds great. The nurses were like, no, but we don't look at results. We look at this other little icon that's up in the corner, and I'm like, I don't understand. Why is this important to you? You should just look in the results place. But they did not like this. So after some discussion and time, we then moved it and said, okay, it still goes to results, but now it also appears in their regular workflow where they're used to looking for their results. And that really helped with them in their response time because now it's kind of baked in. So I think anytime you're doing a technology integration, you really want to map out how do people do something in their regular day-to-day life and map as closely as you can on that system. And so doing that has allowed them to really build this into their workflow such that now they're going off and presenting and very excited about this because it's something they feel like is feasible. So another issue with technology is sometimes there's just a lot of information that comes back. So you can imagine if you have an entire cancer population and you're asking them once a week for symptoms, like there is the potential for a lot of alerts. And we really have thought a lot about how do you reduce the noise. So some of those alerts are very meaningful and going to lead to a save, like the ones that I showed you earlier. Other alerts are just noise. They're a patient who has chronic pain that is going to alert every time with moderate chronic pain. And they want to be truthful. They don't want to lie on their surveys, but you have to do something about that. So we created what I lovingly refer to as the snooze button, which is we have the ability to set an expected level so that if the patient all of a sudden has a severe, we still get notified. But for the next month, none of the alerts for moderate are going to come through. And this has been a huge upgrade in terms of nursing satisfaction because they do want to take care of symptoms, but they want to take care of symptoms that are meaningful. So anything you could do with the technology, making those little tweaks to also get the right information to the right people at the right time is very important. Another big thing for reducing noise is our nurses would say, sometimes I call Miss Jones and she's like, yes, I reported these symptoms, but I don't need anything. So we've now created this option for patients to say, I don't need a call back about these symptoms. I've reported them, but they're managed, they're fine, I'm no longer having them, I don't need somebody to reach out. And then that piece of information also comes to nurse. So they're still gonna get the alert, but if they look at that and they say, yep, this is kind of expected, I know the problem, they can just close it. They can also look at that and say, that's new, I'm gonna call that patient anyways, even though they said I don't need a call back. So it still allows for some nursing judgment, but gives them, again, an additional piece of information to make the process more efficient and reduce the amount of background noise. Another upgrade that we did was hospitalized patients. So I said you want to get the right information to the right person. And as it turns out, if you have a patient in the hospital, the clinic nurse doesn't want to know about the symptoms because then she's like, I'm accountable for these symptoms that are in the hospital and he really needs to go to the hospital team. So we've tweaked the system and we've worked on identifying, where are these symptoms being done, appropriate messaging to the patients that if you're in the hospital, you can still report, but you need to talk to your the inpatient team about the symptoms and removing those alerts from the outpatient staff. So these are just examples, and you can imagine them in any technology upgrade of how you identify a problem, work with the team to brainstorm what are potential solutions, ideally tech solutions that don't involve a lot more personnel time, and then try them. And sometimes we have to make changes, but really having that iterative feedback is key. We've also done some formal patient feedback as well. Patients like this system. It's not surprising. They feel like they're getting more touch points in between their visits. They also, talked about, it's like having a portable nurse, and having a callback when they were experiencing problems. That's a plus. I felt like I wasn't being listened to in the doctor's office. But this program, by itself shows that somebody is paying attention, looking at my notes, somebody's sending me some feedback. So this can really start to bridge the gap as we are having trouble with lots of patients flowing through the system in shorter amounts of time. That extra TLC that they're getting from the nurse in between really can make a difference in how they view their overall care experience. They also want the human touch. I know in the previous speakers there was a lot of discussion about, can we totally replace the humans? I would argue that the right way to think about this is a blend. How do you use your technology to do better and make more efficiencies? But our patients really loved the human touch of the navigator. They liked that person who sat down with them and was like, this program's important, let me show you how to do it. So I think using your staff in a way that makes sense, but still allows them to feel that connection with the team can be very valuable. And it does help communication. So this is another example of a patient just talking about, hearing back from them week to week, knowing that somebody's following and how important and how helpful that was for them. So the physicians generally also like this. I will note that this is a nurse intervention. We particularly designed this to make it very light touch on the physicians because our current triage goes through nursing. So we didn't want to shift that to sort of a new responsibility on our physicians. And one physician says, it's been a very positive experience. A big part of it is the very nature of patients waiting to tell us, what's going on. And this person highlights how this weekly basis is saving them situations where they might not have known that, and they would have waited till clinic, and then it would have taken a huge amount of time in clinic. So we are looking at outcomes. I wish I could show you the answer to all of this today, but we're in the process of trying to understand what are the implications of this on our clinical outcomes. We do know that the symptom management works, that patient symptom trajectories are coming down, but we're really looking at some of these other things like distress and functional status, and then ultimately healthcare utilization, survival for a population of advanced cancer patients, and cost. So I'm going to kind of close with an important point about who does the work. So thinking back to the previous discussion about workforce and how short we're going to be, I just wanted to use another example, going back to that treatment plan that I said in the beginning, about how you can think about teams to do work more efficiently and more effectively. So in the beginning, apparently Siri's talking to me. So in the beginning, we wanted to provide treatment plans to all patients. And so we've done some modeling to say, how could one do that? So in our system, we see approximately 5,800 new patients a year. And if you think about half of them, are getting a treatment plan, it's about 3,000 of these treatment plans a year that we would do. How much is that going to cost? So we looked at the potential for a couple of different models. So if you imagine, a physician model, I'm probably the most efficient person if I were to do this myself because I know all the treatment history. I could just boom, boom, boom through all the data points, but it would still probably take me a good hour, maybe to put it all into the computer and get everything generated and talk to the patient and all of the work that surrounds that. And maybe the second treatment plan would be quicker because I had already had some of that data in. Now, a nurse might take a little bit longer than a physician. And if you had a team-based model with, let's say, a lay navigator who does the patient-reported outcomes collection, some of the logistic pieces, and the nurse really focuses on the clinical entry and the reviewing the information with the patient, you get about the same amount of time with the patient. Maybe the patient gets a little bit more time. But we have to remember that staff with lower training levels, although they may take more time to complete tasks, have a very different price point. So these are the average hourly price per physicians, a nurse navigator, and a lay navigator. And obviously, the physicians are incredibly expensive. And so if you translate these 3 different models, if you have a physician-led model, that's about a $500,000 difference just to roll out this relatively small initiative of treatment planning. So it really starts to help you think about, financially it doesn't make sense for us to do this, but also it's a ton of hours. We're all short-staffed. We definitely need more physicians and nursing at UAB, just like has been discussed here. And to add 1.4 FTEs of physician time is ludicrous. And so that's going to have more shortages, more burnout, more people saying, I can't get into clinic, and the physicians are not going to be happy sending out surveys, doing sort of this busy work that frankly could be done by someone else. So the last thing I want to talk about is really picking tech partners, and we've done a lot of work with different tech vendors over the past few years, and I think there's kind of 3 different models. There is the sort of do-it-yourself model, which is, you build all of the technology independently, you do all of that work. There's the early adopter model, which is where I would say that we are with our patient-reported outcomes technology, and then the package solution model. And I think there are trade-offs, and I think there's not one right answer. This really depends on what is your bandwidth, what are your resources, but recognize that it is much easier to implement a package solution and to just buy something off the shelf and pull it into your team. But you have a lot less ability to customize. So I think you have to look at these solutions and say, what is the lift to develop something new versus how much do I need to tweak it? I would argue right now in the patient-reported outcome space, nobody should be doing it themselves. There are plenty of companies, multiple of them, that are doing this work right now that have lots of staff working on it, have learned this information already. Yes, you may want some adaptations. You may want to be an early partner, but there's also some advantages in terms of time and staff to just picking something off the shelf. And I have an awesome team, so I would like to acknowledge them, my research team, and then I will stop and open for questions.
Hi, Frank Panzarella, Vice President for the Oncology Service Line for Dartmouth Health. A couple of questions. As you looked at did you look at the intersection of your volume of triage calls versus the number of incoming alerts, and how did those 2 things interplay in terms of staffing?
Well, I don't have like an exact perfect, this is exactly how it is. 2 things. So we have just generally looked trends over time. We're up a little bit because our number of providers has grown, but we're not up appreciably different from this program. What's sort of overall volume of work? What's happened though is a lot of our people that called in really often stop calling because they know that somebody's going to check in on them once a week. So instead of calling Monday, Tuesday, Wednesday, Thursday, Friday, they're like, oh, Dr. Roxanne Jenna is going to call me after I do my symptom alert, once a week. So we're seeing less kind of coming through triage, but then more outbound calls. So it's net pretty even is sort of the gestalt I've gotten from nursing who is tracking it, but it's just different. And I think the nice thing about that is, and this is how we've designed it, different people do it in different ways, now the person who's calling them knows them. They're not coming into a triage system where somebody's then forwarding it to my nurse. We've lost one of those handoffs because my nurse was going to answer the problem anyways, but now she's outreaching and we're no longer having the multiple steps to get to her.
Great. Thanks. A couple other questions.
Sure.
I had the fortune of working with one of those technology vendors and with UAB. So I'm curious, when you look at the other remote patient monitoring solutions, particularly those that are Bluetooth connected, Wi-Fi connected, and feed into your EMR, have you looked at those solutions as opposed to just patient reported outcomes to monitor things like blood pressure, temperature, et cetera, to feed those in as well as and have those inform the algorithm and the alerts as well?
It's a great question. So other service lines at UAB have done some of that work in terms of wearables and the monitoring. Yeah. We have not yet wedded those together. I think the future will be, a mixture of these different tools. The way I've approached this, and I'm going to preemptively answer a question that I get all the time, which is, have you customized this to say, different cancer patients get different things? We've really started with, we want it to run across the whole system, and then we want to start adding on. And I do think it's important when you're doing a large-scale implementation to have a little bit of standardization for the workflow issues. So if every nurse has a different set of things that they're responding to, it's much harder for management to say, yep, this is a part of what we do as standard of care. And so we've prioritized sort of standard implementation, and then that's what we intend to do in our next wave is, both customizing the surveys and then also integrating other things like wearables.
Great, thanks. One last question. So as you developed the initial protocols to look at how you would trigger different levels of alerts,
Yes.
And what things you wanted them to report, was that an internally developed algorithm in terms of the escalation, or did you take something off the shelf and customize it? How did you bring your clinical team together of physicians and nurses to really say what are the right things and the right trigger points to escalate to whatever the level was you determined?
Great question. So we started with sort of an off-the-shelf approach using the previous trial data. So we started with those symptoms, and Dr. Bash had worked with the company that we work with to identify, like, how does the Pro-CT CAE score out to make an alert. So we had sort of out of the gate, an ability to say these are mild, moderate, and severe. And so then we did sit down with nursing staff and navigation and physicians and say, do we want to do severe versus moderate? Are we comfortable with this? It was really interesting because I mentioned that I have a partner institution at the University of South Alabama. At UAB, we said we want to get moderate and severe alerts, because if something is moderate, that feels like something we want to know about. My partner institution was like, we're really worried about our call volume, and we only are going to do severe alerts. Interestingly, in the beginning, my nurses, they complained a lot before we started it, but once we got the program rolling, they really like it because they like the fact that they're catching things earlier, and when they get a win, that is such a positive reinforcement for them. And the wins come at the moderate level. By the time that they're severe, it's really time to go to the ER. You know what I mean? Like, you're not getting what you need out of the system if you do severe. And my partners, their nurses were very unhappy in the beginning. And so we ultimately convinced them that the right thing to do was lower their threshold to moderate much better. So I do think that is one thing where getting the feedback is critical, and I think being able to shift and to change. You don't want to implement something and say, this is how it's gonna be forever. And you wanna say sometimes we made a bad choice and we need to step back and do something differently. The other thing is, I mentioned that we changed some of the symptoms out. So that has been sort of an iterative process as well. We got a lot of feedback. Fatigue was the first thing we dropped. We dropped the insomnia later. But we would get that feedback, and when it came from multiple people, we'd bring it back to the group. We'd talk to the nursing supervisors. It was a group discussion before we made a big change, so we're not totally reactionary, but we are taking note when things are starting to come up multiple times.
Thank you for a wonderful presentation. My name is Brett Anderson. I'm a member of the class of 2013. Wanted to touch on one of the last pieces in your presentation around care planning and the resources from a workforce perspective that you're devoting towards them. With so much of a tech and innovation focus of your group, it's very amazing. How are you thinking about some of the new innovations in ChatGPT, generative AI? We're starting to see some organizations use that in some limited fashions, obviously. We don't want them to completely automate the care planning process. Are there ways in which you're starting to think about how to reduce the time of the care planning process? And are there other areas where you're starting to use AI or automation to cut down on things like finding care gaps within the EMR that are typically a time-consuming manual process?
Great question. So we haven't gone sort of fully to AI. I mean, there's discussions about that, I think, in all health systems. The times that I showed you were before we did a lot of sort of interfacing. So one of the pieces that took a long time for our staff is going back to the clinical records and saying, this is the patient's treatment and these are the dates, and sort of all of those details that need to be in the treatment plan. So since then, we have done work so that the orders flow directly into that. So now it's kind of pre-populated, and yes, it still needs a review to make sure it's okay, but now you have a lot of that information automated. So if we redid this now and we re-asked the nursing staff, how long do things take? It's less. But it still does take time, and that's why we tried to build other things onto that. If I'm gonna ask, a nurse navigator to spend even 40 minutes, you know what I mean, working on this thing, it better have a lot of output and not just a piece of paper at the end. So I think there's a huge opportunity. I think we're limited to some extent by the frame we have, because I've heard super clearly that people want to work within one system. And so we have to think about, how does the technology interface with that? I would love to have more of this automated, more things flow in, the risk alerts pop up. And I think the solutions exist. It's really the interface where I think we've had the most trouble.
Thank you.
Thank you so much for the hard work and the great presentation. I'm Andy Nemechek. I'm from 16, and I'm in oncology as well in the head and neck space. You have a great enrollment rate of around 20% consistently. Do you have to have a parallel team to work with your other patients that are not enrolled, and how does that affect your workflow?
So the enrollment rate, which is like coming up, there's a few factors for why it's not higher. So one is, we have had some areas where we have intentionally rolled out slowly, and that's often because of staffing issues. And so in the beginning, it takes the nursing staff in particular, they're a little resistant before they start. And so in places where we're down physicians or down nurses, we've done what I refer to as the slow roll, where we had one group where we said, all right, you have one person who left, one person who's out on maternity leave, and you're down to one doctor in that disease type, so we did 2 patients a week. So with the plan that we graduated from 2 to 5, and then after a few more months, 5 to open. So we're missing some patients because of that. We are also missing some patients because we are doing disease group by disease group. So we haven't rolled out at every single disease group yet. So I would not recommend doing everybody across the whole system at the same time, because they need a little extra TLC. I send one of my team members over to go chat with them to make sure they know where things are in the record. That sort of support is key. We are still missing some people, and doing work to figure out. That's why I have that report, so that I can get it back, and we feed back to those teams. These are the people you missed. Go back and look at them to understand what are the systems related issues to missing people. Another thing that has helped, I think, recently is I showed you that we have sort of all those, the list of screeners that we're doing for new patients. That also, because the navigator's involved in that, it's also now easier to identify, this is a new patient, I've reviewed all their issues, I'm now waiting for them to start on treatment so I can start the symptom assessment. But the people who aren't on it right now, because they've refused or we've missed them, are not getting any sort of additional extra support.
Hi, my name is Will Tari from Psychiatry here. Very wonderful presentation of an innovative, interesting workflow project. When you start to look for depression, or whenever anyone looks for depression anywhere, they find a lot of depression. So in some of these interventions, it was quite clear that the nurses could do them or other people could do them. But how did you, I know you went through it kind of quickly, you built out some mental health into the system, but how did you think about that, and what kind of providers did you, how did you do that part?
Yes, this is a great question, because we actually intentionally split things. So if you look at the original studies, that this kind of whole program was based on, they actually included some of those kind of psychiatric complaints in the weekly symptom assessment. When we met with our teams, we made a very strategic decision to separate those. And so we do have the depression screens on that intake visit, and then they get it each time they come into clinic now. But we did that because it needs to flow to a different group. And so the depression screens do not flow to nursing, they flow to the psycho-oncology program. And so that's another thing that I think is important about patient-reported outcome development, is you have to be able to get the alerts to the right group. So for example, there's a oral adherence option that we could add on, and we haven't done it yet because I need to make sure that that gets to pharmacy instead of to the nurses. So we did find a ton of depression, and we started with 1 and then 2 and then 3. And so we have grown iteratively over time that program. And the way that has largely happened is a combination of bringing the data back to our administration and having them understand the value in that and the volume that needs to be served. And I will say we have a very forward-thinking administration that does genuinely care about the whole person and has been willing to work with us on making the business plans and all of the work that goes behind that. The other thing that the lead of our psycho-oncology program has done, which I think was really innovative, is developing this training module. So she does have interns and people that can kind of expand that capacity as we're like waiting on the business case to hire another person. There's a little bit of flex in the system because of the fact that we have kind of trainees that are working underneath her as well.
Great. And just since no one's at the mic, what have you from your psycho-oncology program? Do you know what impact that has on the oncologist's job?
Oh, we love that program. So I will say, out of everything we did and all of our oncology care model work, by far the most popular is the psycho-oncology program. I mean, the physicians love that program. And it was funny because we have 1 or 2 naysayers in our group who initially were not super keen on this, and we're like, what? You're sending me these things and I need to refer. But really, it is smooth. And actually, the oncologists no longer do it. It's all kind of automated. Everybody's bought in. And people love that aspect because honestly, those patients are hard to work with, and getting them the appropriate mental health support and counseling has been so helpful for just working through those issues. And I would say too, it's one of the things that helped us with the pandemic is that did move really largely to virtual, so the patient acceptance of that went up substantially for us, and that has made things a lot easier for the oncology teams.
Thank you.
All right. Oh, thank you.